recording and let me.
Okay. Welcome to PEPI, Project ECHO for Primary Immune Disorders. Thank you all for attending. As you know, PEPI, or Project ECHO for Primary Immune Disorders, is focused on education and improving outcomes for patients with primary immune disorder residing in rural spaces. Today, we have a true pleasure of hearing from Angie Tyree. Angie is a nurse who runs the office, the clinical operations lead at Collaborative Health Pediatrics in Lynchburg. She also is a former critical care nurse, so she's a wealth of both administrative and clinical skills. She's also the engine that runs PEPI. She coordinates all of our programs, so when you get emails, they're from her, and she makes sure that content is available to our many listeners. So very excited to hear from Angie today as she talks about practical tips regarding administration of both IV and sub-Q immunoglobulin. Again, thanks to everyone for being here. And Angie, take it away.
All right. Well, I was going to introduce myself, but I don't have to anymore. Thank you guys for attending. As Nick said, my name is Angie, and if you've been on a PEPI session, you have seen my face. So a little bit about me. Extra, I've been in the medical field for about 18 years, and I am a pediatric nurse. That's where my heart is. And I truly enjoy taking care of those patients with complex needs. And so with the majority of our patients with complex needs, what do they need most of the time? That will be infusion. So I'm going to go over some basic infusions and go over the differences between them. So what our infusions today is about is immunoglobulin therapy. And part of your immunoglobulin therapy, you can get it via IV or subcutaneous. And IV immunoglobulin therapy is given straight into the bloodstream via the vein, and subcutaneous, most of the time given at home, and it is given in the subcutaneous fat. So pros and cons of IVIG and sub-QIG. With IV, you have fewer infusions. You are not in the hospital or infusion clinic, but once every 3 to 4 weeks. And with that, you can get a high dose delivery. And this is great for people who need a fast treatment, that are in crisis and need to get their levels up. Cons of IVIG is that it requires hospital visits or going into the infusion clinic, and you're at a higher risk for systemic reactions because you're getting a higher dose. Administration times are several hours. So if you have a patient that has a very busy lifestyle and they may not want to sit in the hospital for hours at a time, but on the other hand, they're only having to do it once a month. This is also a costly treatment because you are having to go into the hospital or a infusion center in order to have an infusion done. And this type of infusion is better for patients that want shorter and fewer, well, they want fewer infusions. Subcutaneous, this is a great way to infuse immunoglobulins because it can be administered at home. And then you also have a more consistent antibody level because you're getting more frequent, smaller infusions. And because you're getting smaller infusions, you have less systemic side effects, but it does require more infusions. And most of the time, this is weekly. You can have local irritation at the injection site, which is pretty common, but there are shorter sessions weekly, and they're lower cost because you're doing it at home. So, and then sometimes people have nurses or loved ones that have mastered how to give these infusions, and you don't even have to have a home health nurse sometimes to infuse these. And this is more suitable for patients who are busy and on the go. Some of these patients even have learned to set themselves up, start their subcutaneous infusion, and then go on with life and have it done that way. So a little bit more about the perks. For IVIG, it's widely available in a clinical setting, and it provides a safety net, especially for patients who are at a high risk of complications. It's less frequent dosing. Like I said, you only have to have it every 3 to 4 weeks, and it's a rapid immune boost. It delivers a large dose of immunoglobulins in one infusion. So this is giving more beneficial response for people that need a fast onset. Still more with perks, it's only one site for administration, and sometimes with subcutaneous, you have to do multiple sites for an infusion. And then rapid symptom relief and easier for severe conditions. So the drawbacks of IVIG is you're going to have a greater risk for side effects because you're getting a larger dose at once. So you can have anaphylaxis, headaches, fever, more serious complications because you're getting more fluids, kidney problems, and clots, fluid overload. It's inconvenience. It requires a lot of time in the hospital setting or the infusion center, and it is highly costly. First, subcutaneous, faster recovery post-infusion. They're smaller administered doses, so you can recover a little bit quicker than you can with the larger infusions. And it can improve quality of life because, like I said, you're able to do it at home and it has fewer side effects, and you can do it on the go once you get your system down. And there's less risk of fluid overload because you are not getting such a high dose at once. It's less costly because you're not paying for a clinic setting again. And then also you have more stable serum Ig levels because you're getting small doses several times instead of one big dose at once. So it kind of stays there in your system a little bit longer. The drawbacks of subcutaneous, you have frequent injection sites. Sometimes with one infusion, you'll have 1 to maybe 3 sites, depending on what your dose is. And it can be uncomfortable at times, and especially those patients that you have that just really hate needles. And you can have localized injection site reaction. So in the picture below, you'll see this is what a general site looks like. This is someone's abdomen, and you can see where the injection site is, and you can see the redness and the irritation. This is mild and temporary, but this is what can happen. And then also for both IV and subcutaneous, most of the site irritation can come from the type of tape we use, Tegaderm and things like that. Also, with subcutaneous, you're getting loved ones to learn, and you're getting the patient to learn how to administer this medication at home. So if they have learning curves, it's a lot for someone to have to take on. So they feel a little bit anxious about having to give themselves an injection, and it can be a barrier and require someone having to come into the home to be able to give it. And if it's a patient that needs, a fast action, this may not be the way to go because it's a slower onset because you're getting a smaller amount of medications each time and require frequent injections. The adverse reactions for your IV, your mild reactions are headache, fever, chills, nausea. And to treat those, you just give Tylenol and antihistamines, and that'll help with the fever and headaches, and the antihistamines to help with mild itching. And with subcutaneous, the mild reactions are a little bit less. You can have, it's mainly injection site discomfort, redness, or itching. And the way to treat your patient that has an injection site reaction is a lot of ice. That helps more than anything. It helps with the itching, but you can give the antihistamine cream, Benadryl, that helps with the irritation. Tylenol and ibuprofen for pain if needed. And more of your moderate reactions with IVIG is persistent headaches, significant nausea, or systemic symptoms. And a lot of times you have to give IV fluids to help with dehydration, especially with the nausea if it gets continuously worse and they're vomiting, and Zofran to treat anti-nausea symptoms. And you need to closely monitor their vital signs. They can have blood pressure issues during these infusions. And with the subcutaneous, kind of the same. They will have persistent pain, swelling, and mild systemic reactions like headache or nausea. And with that, you're going to encourage them to drink. You're going to give them Zofran or some other kind of anti-nausea medicine and give them cold compresses and just help them as much as possible with injection site reactions. And severe reactions are pretty much the same with both. It's your anaphylaxis and your kidney injuries, and they need immediate intervention. So if you see this coming with either one of your patients, you're going to stop your infusion and you're going to administer epi. If you're doing the subcutaneous at home, you're going to call 911 and continue to monitor if IV fluids are available at home. And if it's a home health nurse that's working with this patient, she can start to administer IV fluids due to hypertension. But with your IV, you are doing this in an infusion clinic. So for hypotension, they're going to give IV fluids. They're going to do epi and, escalate your care. Moving on. How do you choose the right route? Should you do IVIG for your patient or do you want to give it subcutaneously? So your physician will order based on the severity of condition. IVIG is a deal for acute severe conditions that really need that immediate support because you can give that bigger dose right up front. Subcutaneous is someone that has a chronic condition and they need long-term management. Like I said, IVIG can be administered higher doses in one session. Subcutaneous is smaller doses and more frequent administrations. And you also want to consider your patient's preferences. Subcutaneous allows self-administered, increasing inconvenience with home administration. And then IVIG requires these long clinic days about once every 3 to 4 weeks, once a month. And then the risk for side effects. Think about your patient. Are they high risk? Do they need to be monitored in a healthcare setting? Do they have kidney issues, heart issues, prone to anaphylaxis for other things? Subcutaneous, they are lower risk of systemic reactions. So maybe your patient with kidney injury, any kind of renal problems, subcutaneous may be the better option for that patient. And then you also want to think about their lifestyle considerations. Subcutaneous probably will be better for a person that has a really busy lifestyle. And IVIG, the longer times may require more significant time commitment. So you want to think about what that patient does for a living. And it's more about making sure their quality of life is better because it's bad enough that they're going through having to have IVIG and going through having immunodeficiencies. You want to, think about that patient and think about what would be best for them and how much they can live the best normal life as possible. This is kind of what I've already went over, but evaluate their overall health. Now, everybody in healthcare already knows this, but I went ahead and provided a picture of someone getting IVIG. This is through the vein. And this is what a lot of people don't realize who work inpatient in the hospital. This is a subcutaneous setup. As you can see in the abdomen, they have a small subcu needle that's entered into his subcutaneous fat and it's given through a syringe. And so when you give these subcutaneous doses, that may have to be administered in more than one site. So that's 2 to 3 pokes. And this is how it's infused. Does anybody have any questions? Here are my references. And here's some information about our next echo sessions. We have another one on November the 5th. And here is a link to our YouTube channel as well as our email. Scan this because we want to hear more from you. And then I'm going to turn it over to Nick.
Angie, thanks so much. Great job. Just a couple questions. I think as a as a physician, I engage in shared decision making with patients, as I'm sure all my colleagues, who are listening do. And, we often, present that, IV and sub-Q are therapeutically equivalent, for immunoglobulin replacement therapy for patients who have primary immune disorders, but that there's just a wide variety, as you beautifully showed and discussed, of lifestyle modification, or lifestyle factors that go into the decision, in terms of deciding sub-Q versus IV. And when a patient has not been confronted with this therapy before, it can be a little bit overwhelming. And so, we write for it. We think, okay, we've got a great plan for the patient. We've discussed it in the office setting, and then we move forward, and and the patient, comes back in, and we ask questions like, how's it going? But when they're new to it, they don't kind of know anything different. I mean, they know I chose IV, so I come in and I get an IV place, or I choose sub-Q, and I do it myself every week or every 2 weeks or even once a month, depending on the product. But then there's a lot of dialogue, I think, that happens behind the scenes that we're kind of unaware of. And I feel like the nursing team and the infusion specialists have a really important role, and a unique skill set that we don't have. And I wondered if you could just maybe even share a little bit more about, obviously just general your experiences, and how some of that plays out, and ways that that you really allow for the patient to have a great experience with infusions, and maybe even if there are things that as physicians, we could possibly do better to support you as you're interacting with patients. So I know that was a lot thrown at you, but just interested in your thoughts.
Well, in my experience, I'm a chatty Cathy. I talk with all my patients. I talk with them a little too much. I get to know them a little too well and get a little too close with them. I'm very guilty of that. But when I talk with them, I talk about their lifestyle and what's going on. And what time I try to, so past patient experience, I try to take into consideration what they have going on. And like you said, they don't know what they've had. They've only had IV or they've only had subcutaneous. How do they know that that's the right choice for them? So when I talk with them, I ask them, how's it going? And they're like, oh yeah, this is great. This is great. And then as I talk with them, delve in to see that it's actually impacting their life with them having to come into the hospital and sit for hours and hours, I may end up talking to the physician to have them delve a little deeper. And I know with our busy schedules, sometimes we can't spend as much time with our patients as we would like, but I would just recommend trying to get to know your patient and what they have going on at home. Because a lot of times when they come and they get that 15 minutes, their 30 minutes with their doctor, they're talking about their illness. They're not talking about their impacts of life, and what's going on in their life, or because they're just getting those short minutes with their physician because schedules are so busy sometimes. So just try to delve in as much as you can while you can with your patients. Did that
Thanks for
answer
that.
that
Yeah, no, that
question?
was great. That was very helpful. Thank you. Thanks for your perspective. Any other questions? If not, I do have one more for you. I wondered if you can even just, I don't know, prognosticate, if you will, or if you have specific examples, be interesting to hear them. Do you think there are some differences between kind of the experience in giving immunoglobulin replacement therapy amongst individuals who live in rural spaces versus urban spaces? Do you think there are unique factors or unique kind of approaches or considerations depending on where the patient lives?
That is a great question. And yes, I do. I think it impacts, I think where you live impacts you greatly. And I do know that you don't have access to health when you're living in a rural area. And sometimes finding home health nurses to come out to actually teach patients, that can be time consuming because there's not a lot of resources out there. The more rural area that you live in, the harder time you have to find an infusion nurse to come, a home health nurse. I know advances are getting better and better, and it's being brought to the table more often. But if you live in a rural area, sometimes you're not able to have home health because home health isn't available at those areas. And that kind of forces the hand of the physician to have you get IVIG in the hospital once a week in that setting because their home health is just not available at that time unless you have a family member who works in healthcare that is willing to learn how to give those infusions. But then you're also putting extra onto the family because they're already adjusting to having a disease or an illness that has to be treated, but now they have to be forced to learn to take care of you instead of having that home health nurse be able to come in and monitor things for you. I have had patients while I worked in the hospital due to not having home health available in the rural areas that surround the hospital that I work in, force the hand of the doctor to be able to write infusions in the clinic instead of at home due to the lack of nursing.
Yeah, that's super helpful. Thanks for that perspective. And I know that, kind of, we didn't rehearse this at all. So it's really awesome to hear your impressions. And, that does lead to some thoughts about technology and ways that technology can augment, the healthcare professional, but also support the patient. And so, for example, as I already described, I may, of course, and I will, if I'm prescribing immunoglobulin to a patient, engage in shared decision making and talk to them about the therapies and the indication for the therapies and get a sense for their preferences. And then, not really at that visit ask them for a decision, although sometimes they will make that decision at the initial visit when we talk about IgG replacement therapy. But then, obviously infusion specialists play a huge role in this. But there are a subset of patients we know who, really do struggle a little bit. They've chosen sub-Q IgG replacement therapy, and it's ideal for them, fits into their lifestyle, for example. And they go home and they find that, wow, I saw how it was administered, and then I did this correctly under the watchful eye of a trained healthcare provider, either a physician, advanced practice provider, or infusion specialist, or other experienced individual. But then I'm left alone to my own devices, and like suddenly it's real. Like I'm at home alone with my infusion, and I have to troubleshoot. And we have had patients come back and say, yeah, I was a little unsure about this or that, or this happened or that happened, or do I prime the fluid all the way to the end of the needle, or do I dry prime, or what happens if I pull back and I see a flash of blood? And these are just very good practical questions. And so I know that there's some technology out there that's being piloted and developed, including an voice AI that would be trained to support patients and answer specific questions directly about the infusion process. And so I think technology like that is probably going to become more prevalent in this space. And I do think that independent of where a patient lives, certainly if there are challenges with access, this type of technology may play a greater role. And so that's one hypothesis would be that something like that may support a patient who is at a distance from healthcare more than someone who lives in maybe a suburban or urban area where healthcare is more readily available. But yeah, any thoughts on that from your perspective?
I think that would be amazing. The only thing that I would worry about there is sometimes when you live in a rural area, you have lack of access to technology and with the internet and things like that. So making sure if there is AI available for that patient, I think that would be awesome. The only concern I would have is internet connection and that failing and things of that nature. But I think if we can't staff nurses or healthcare providers that are there for the patients, that would be the best option if they're able to get a good, suitable connection for the internet.
Yeah, I know the digital divide is important. I'm glad you raised it. Certainly that is an issue. We still see, in Southwest Virginia, areas where, cable and fiber, or I should say fiber internet is being laid down, but this is in areas where patients typically did not, or families did not typically have widely available consistent internet. So, we actually see this not far, from where we practice in Lynchburg, Roanoke area. So that digital divide is really important. And then I think also just underscore that I think these technologies are still being envisioned, really for the way distant, future to augment the healthcare provider. So that would not replace a clinician would not replace an infusion specialist, but it would augment and support and perhaps improve the quality of life and experience of a patient who's already been trained by a healthcare professional in terms of their administration. So fabulous. Anyone else with any questions? Just want to make sure that I'm not dominating all the question asking of Angie. And hearing none, Angie, I just want to thank you so much for sharing of your deep wisdom, knowledge, and really great practical understanding. Thank you for just sharing this information. I think it's incredibly important, and we'll continue to make difference for patients in terms of their outcomes, but certainly their experience. So with that, we'll close our session for today. Again, I want to thank all of our attendees and anyone who may view this online on our YouTube site, which is there in the chat, as is our website. And we'll see you hopefully next week at our next session. Thank you, everyone.
Thank you.